and all those missing charts, and so we're trying to pre-screen those out as much as possible so that you're not getting stuff that you shouldn't get. But if you ever have any questions about what a coder's needing, why it's being sent back to you, you can always take coders involved.
That's an important point to make, that there's a lot of pre-screening going on now.
Yeah.
That wasn't as much before, so you should get less nuisance charts.
Yeah, it's going to be hard to get that to 0, but yeah, because sometimes coders want what coders want. So I want to talk to you today about some documentation of the medical record. Now, I'm a coder. I'm the director of coding out of our Jacksonville office. So I'm going to talk to you from a coder's viewpoint here about documentation. I don't actually do documentation, but I need documentation to do my job. So I think it's good for the providers to know exactly what coders are looking for when they're trying to apply codes on the medical record. Sometimes there's a lot of questions about that. What exactly do coders need? What are they looking for? Well, I want to take you through this and just start with some general principles, and I want to talk about E&Ms, Evaluation and Management Codes. That's your level of service. That's your bread and butter in any ED practice. Virtually every patient that walks into an ED is going to have an Evaluation and Management Code, or E&M. Some may have procedures, some may not, but E&Ms are your bread and butter. So documentation of your E&Ms is probably the most important thing from a coding standpoint. And there's some general principles to E&Ms. I'll warn you now on slide 1, I'm not going to read everything on these slides. There's a lot of information in these slides. We can make these available for you later, but I'm just going to give you the hot points and the quick topics on these. So if you need me to backtrack, just let me know. But just a couple of points about general principles. One is that you need to tell the whole story of the ED visit. Your documentation should be a start to finish story of the encounter that you had with that patient. It's the only evidence we have from a coding standpoint of what really happened during that visit. And the very last bullet point here is coders live by this. If it wasn't documented, it didn't happen. Coders cannot consider, we can't do assumption coding, we can't assume anything happened. If you don't document it, we can't code for it. Signatures are also important. Now signatures will, a lack of a signature will cause Justin's cool tool to send you some emails because we don't get the chart until it's signed. The signature a lot of times releases the chart to come to us. So the documentation may be complete, but if you haven't signed the chart, we don't get it. It delays your reimbursement, and you get emails now from Justin's tool. So please make sure that the signatures are done. And if you sign them timely, then you'll never have a reminder to do those. But when it comes to E&M coding, there's 3 key components to an E&M code. There's your history, your exam, and your medical decision making. And I want to really talk about medical decision making because that's the driving force to any E&M code. Medical decision making is the acuity level of the patient, how much work it takes for you to establish a diagnosis, therapies and diagnostics. What's your thought process? How much work did you have to put into this case? In other words, no matter how much history and exam you document, if it's just an earache or an ankle sprain, it's probably not going to be more than a level 3. So history and exam aren't the driving forces. Medical decision making is. So it's important for you to know what counts in medical decision making. And I'm going to give it all away right now. Everything counts. If you do it, document it, because coders look at every single activity, order, conversation, everything that you do for a patient, and we consider that in medical decision making. Another thing is that I can't tell you when something's missing. The downcode section, remember the bottom section in that screen that Justin was showing, talks about downcodes. Downcodes will tell you if there's not enough history. You didn't give me enough ROS elements. I'm sure you've all seen that before. Or an exam. I can tell you when that components are missing because I know what I need. I can't tell you when medical decision making is missing. I can't tell you if, I don't know if you had a conversation with Dr. Smith and forgot to document it. I don't know if you did a reevaluation. I don't know if you got a second shot at Demerol. I have no idea, because if it's not documented, never happened in my eyes. So I can't tell you if you're not documenting your medical decision making correctly. All I can do is tell you what we look for when it comes to medical decision making. So, yes? I'm going to grab my water. Great.
That's right. So I may have 0 downcodes in a whole year,
right?
But my RVUs are really low
yeah.
Because I'm not putting enough in that portion.
You should be really happy you're here today. I'm gonna help you out with that.
Yeah.
But we can't track it. We can't track missing MDM.
Right, okay.
And what we find a lot of times, especially in this type of a format, so you've got a really good documentation tool, but everything that we rely on getting is from your documentation, because we don't get orders, we don't get nurses' notes. We need this in your documentation. And since everything counts, everything needs to make its way into your documentation. And some of the stuff that you're going to see up here, you're going to say, I do that all the time and probably never document it. So this will help. It'll help. Now, is it going to take what I tell you today, it's not going to take every 3 to a 4, every 4 to a 5. Medical decision making it's one of those it is what it is type of things. But if you do it, make sure that you document it so that we can get you the credit. Because if you're not documenting these things, I guarantee you we're undercoding, but it's not showing up in the downcodes. As a matter of fact, if you start documenting your MDM better, you might actually have an uptick in your downcodes because the acuity level's higher and we're looking for more history and exam. Not a bad problem to have. So there's 3 different categories of medical decision making. We try and look at the number of possible diagnoses and management options. We look at the type of data, and then we assess risk. And it's this complex point system. I'm not going to bore you. You're going to just think my job is very boring if I get too into the details. But these are the different types of things that we're looking at. Labs, orders. Obviously, if you order labs, you order x-rays, you order EKGs, it's important to know that for a coder. Again, it's a point system, and so each one of these things adds points or values. Remember, there's 3 different categories, so just because you have a lot of points in one category doesn't make it a level 5. It has to be 2 out of the 3. But these are the different things we're looking for. So I'm a coder. First thing I'm going to do is look and see number of possible diagnoses, management options. Did you have to order multiple ancillaries or a special study? Did you admit the patient? Those types of things. And then I start counting the data points. I look for orders of labs. I look for orders of x-rays. I look for orders of EKGs. I look for discussions, an old medical record review. Right there is probably the 2 biggest things that physicians frequently do and fail to document. So let's talk about discussions. Anytime you talk to another healthcare provider, document that. It's worth a lot of acuity. Medical decision making is trying to assign points to your time, your clinical expertise. Not an easy thing to do. But if you have a discussion with another healthcare provider, that could be the EMTs that brought the patient in, nursing home personnel, poison control, another doctor. Doesn't count for residents talking to their own attendings because that's, assumed to have happened. But any other type of conversation with a healthcare provider, document it. Old medical record review. Interesting thing about these points were developed back in 1995, the year I started coding. I'm almost embarrassed to say that anymore. Back in 1995, remember how hard it was to get old medical record review? They weren't at your fingertips. You had to ask somebody to call the other hospital, and Sally had to talk to Joan, and Joan had to fax it over. It was quite a big deal. So even though it's much easier to get old medical records now, the points haven't changed. They're still worth just as much. And how often do you find yourself reviewing old medical records on a patient, pulling that up? It's at your fingertips now. Every day, I know, maybe even every patient. How often do you document that? Make sure that you're documenting that. It takes your time. You're looking at that patient's history. It could be as simple as looking for an old EKG tracing and comparing an old EKG to today's EKG. That's old record review and summarization, yes?
Some people list their review for previous medical records in the medical decision making. So
yes.
People at the end of the chart, they say interpretations, previous medical records. Is there a difference in how you do it?
Coders, we've learned the hard way that we have to look everywhere on a chart. And so medical decision making, we use the entire chart. The one thing I will say is that the points are for the old medical record review and summarization. So just saying old medical records reviewed, that's not enough. Tell me what you found or didn't find. It can be a negative comment. I just need to know what you were looking for. Old records reviewed, not admitted previously for saying. Negative comment, but I know what you were looking for. You get the credit that way, but I need a summary.
So the difference between the second and the third one are what?
The decision to obtain old medical records, that is only available when you want to look at old medical records, but they didn't get to you on time. That's the old Sally Joan fax point.
Okay.
So if you ordered them but were unable to get them while the patient was
Oh,
there.
from the hospital, they never showed up.
Yeah, or the EMR system's down or something like that. I tried to look at old medical records, system down,
So
system
generally, we're
downtime.
doing the third one, if we discussed that we review those records. And
2 points.
okay.
2 out of the 4 in this category. And it's the #1 thing we find that providers routinely do and fail to document. That doesn't mean that every chart is now going to be a level 5. It's not going to do anything for your earache patients or your ankle sprain patients, but those borderline 3 versus 4 or 4 versus 5, it could be the one thing that takes the acuity to that next level. And it's appropriate, so just make sure you're documenting that. And your independent visualizations. We do bill separately for EKGs, and so we know that you're looking at your EKG tracings. But do you find it routine that you're also looking at x-rays? Maybe that you're actually independently viewing the film itself? Or are you just looking at radiology reports?
Okay, I have a question about this one. So
Okay.
I look at all my x-rays.
Do you tell me that?
So yeah, that's my question. So sometimes when I look at the x-ray, there may be a report already and I'm reading that.
Right.
But I'm interpreting it on my own.
Right.
Almost always, unless it's a CT or
You
something.
need to let me know that. It doesn't matter who's billing for it. This isn't about billing the x-ray. This is about your time and your clinical expertise. And let me tell you something, not everybody can read an x-ray. So even if it's overread, even if you're looking at a report, if you actually look at the film itself and form any form of interpretation, even if that interpretation is just negative, make sure you say, interpreted by me, viewed by me, and you'll get credit here in the medical decision making.
Yeah, so my question is, if there's a report up and I'm looking at the report, how does that jargon
But are you
work?
looking at the actual film itself?
Yes.
Okay.
So I look at an ankle x-ray, because a lot of times I'm calling a radiologist and say, hey, you missed
Right.
a fracture, whatever. But he's saying
Wow.
it's negative. Well, we all do that. But I'm just saying the difference between the report and should I dictate, I review the ankle x-ray and interpret it as negative, and then the report,
You don't need to tie your findings in with the radiologist's findings. It's not from a coding perspective. Now, from a risk management perspective, that might be something different. But I'm only talking about coding. I just need to know that you looked at the film itself and you weren't just reading someone else's report in order to assign these 2 points.
Okay.
And this is another big one. Now, if you're doing an x-ray and an EKG, I know that you looked at the EKG because we bill those for you. But since we don't bill x-rays separately for you, you have to spoon feed it to me and say, I actually viewed, not reviewed, viewed. I viewed the film. I viewed the not just the report, but I viewed the x-ray.
Yeah, interpreted.
I interpret, it doesn't even have to say that, just give me something negative.
Oh, reviewed is not an acceptable.
Reviewed
word.
is a little arbitrary because reviewed, what did you review? Did you review the report? Or did you view, because this is an independent visualization, it has to be yours, not a review, which is someone else's work. Stay away from review. Yes?
Okay, CAT scans, I'm not saying I'm interpreting them my own, but if I view the image of the CAT scan, should I be documenting that I viewed it? Or is it
We're not going to give you credit for that.
Okay.
Yeah, nice try though.
No, I do. There was one to-
No, it's a great
Thanks for
question.
that.
CAT scans are a little bit different than the wet film, so. Great question. All right, that takes us to risk. Risk is probably the most complicated thing for coders. Everything else is a point system. We like points. We see this, we give a point. But when it comes to risk, we're trying to assess the risk, and risk can just be anywhere on a chart. Sometimes they present with a complaint that is potentially high risk. So a patient comes in with chest pain, gets that full cardiac workup. They present potentially high risk, everything's negative, they get to go home, turns out to be heartburn. Presenting problem, I'm going to still assign a high risk for that. So it'd be a case where it's in the front side of things. Sometimes it's the actual therapy itself that assigns the risk. Parenteral controlled substances carry a high risk, and so multiple doses of morphine or Demerol would indicate a high risk to us. Sometimes it's the differential diagnoses. Differential diagnoses are extremely helpful for coders in trying to assess risk. Now, you might have been told in the past that differential diagnoses aren't good to document. And that just means that we can't code them, that you can't actually assign an ICD-10 code for a differential diagnosis. So while I can't assign it a code, doesn't mean it's not helpful, because it does help in risk in trying to figure out what that patient potentially has. And so differentials actually very helpful. Some other things that contribute to risk, we already talked really about your workup. What about your treatments and interventions? Remember, it's your documentation that we're relying on, so we're really looking for you to document clearly your medications, the routes of medications, doses of medications, whether you have to repeat those. PO meds carry a different risk level than IM meds, which is different than IV medications. And so routes of medications are important because you have to repeat that route. Just saying analgesics given or Demerol given doesn't give us the route of medications. And remember, I'm a coder, so if you don't document it, it never happened. So I want to make sure that you're getting credit for the treatments that you're providing. So routes of meds. I don't necessarily need milligram dosages, but I do need to know the route. If a med is available in a PO form and you don't tell me, I have to assume the least and assume it's a PO med when you probably gave it IM or IV, especially like morphine or something like that. IV fluids, if you have to repeat the meds, give me that. Nebulizers. And then repeat evaluations. This is another thing I think that occurs quite frequently that doesn't get documented, and it helps a lot with risk. Once you provide some form of therapy, like a pain medication or a nebulizer treatment, how often do you go back in the room later, look at the patient and assess their response to that treatment and do that reevaluation? Often? And how often do you document that? Not so often. It's medical decision making. Make sure that if you're doing it, that you're documenting that. And it doesn't have to be anything fancy. It can be check patient after second nebulizer, looking well, ready to go home. Something simple. But just let me know that you went back in that room. How did they respond to that treatment? And then disposition. You'd be surprised at how often we're missing a disposition, and sometimes we actually have to send those charts back and ask what the final disposition was. Remember, your documentation is the full story of the patient's encounter. And if you don't tell us the disposition, it's a cliffhanger. We don't know how it ended. We need to know. Yes?
I get these charts back a lot that want me to say where the patient was discharged to. I don't quite understand that. Like I explained before, I don't know what they do when they leave.
So discharge.
Like they want me to put to home or to a facility or something, and I'm like, well,
I'm not. I don't know that I'm sending those back to you. Is that something internally? Okay.
It's hospital. It's a hospital.
Well, when you say discharge to home, I mean it just means that you're sending them home rather than I'm discharging them, but they need to go directly over to this mental health unit or this residential treatment facility or something like that. So I think discharge to home doesn't necessarily mean they're going into the little house with the white picket fence and all that other stuff.
So, you made a comment that the route is important, and obviously that's how they pay you for the route, and you said the dose is not important. Don't you bill it based on the unit?
We don't actually bill for the supplies.
You don't?
I'm just talking from an ED coder, professional fee service. I'm not actually billing for the medication because you don't own it.
You're billing for the
Right.
route.
I'm just counting that into your medical decision making. What's the acuity level of this patient? And obviously, if a patient requires IM or especially IV controlled substances, their risk level is going up because their problems now are more severe or their pain is more significant. That's all I'm trying to assess. The milligram dosage is helpful. If I had to pick milligram or route, I want the route. Yeah, I'm a little picky like that. So yes.
No, I'm sorry, on the back.
No, I love the questions.
That's obviously easier for you guys to pick up and send the chart, but are you guys able to review the orders or anything?
No.
Okay. So if
No.
you put it in, there's no way for you guys to know.
That's correct.
Okay.
So like your power orders,
Yeah.
I'll see them. So make sure it's in your documentation. And I know that's a little bit repetitive, but that's the only way that I'm going to see it.
That is something we're going to address. It's been a while since we talked to the DNC about trying to parse that out. Because remember, we can only get minimum necessary information, and previously when we tried to do that, it pretty much gave us the whole patient record every time they've been here, and we really don't need that. So but
And if
we're
they
going to
get
readdress it
admitted,
again
it's a
and
400
see if
page
we can
chart.
get it down, just the information related to that patient's visit. It came up at Grace this morning, and we'll
Discharge paperwork.
we'll see, and try to get the
For a
discharge.
cross-cutting measure, So, it's interesting that documentation, the way to improve your documentation also makes for a better defensible medical record. If you're just documenting what you do, coders have everything that they need, you're establishing medical necessity for that patient, and it's just a well-documented record. So in addition to just the coding and billing aspect of it, it's just a better medical record. And medical necessity is something that it's a big hot topic in the industry, and a well-documented chart helps to establish medical necessity. So final diagnoses, guys, make sure that you give us a final diagnosis, especially with the advent of ICD-10. It's really important to have a specific final diagnosis. Now, I will tell you this. It's okay if your final diagnosis is a rule out or a differential, or even the same complaint that they came in with. It's an emergency department. You're not expected to provide a definitive diagnosis on every person that walks in, but provide that diagnosis, because if you don't, then coders have to start digging through the record and pulling things out to code. That's just not how you want your medical record coded.
I thought we were told not to use their.
That's the hospital, so I think, you gotta think about it for the hospital's sake.
So we really shouldn't be using it.
Yeah.
You can do both. You could put chest pain rule out MI. I mean, you're still giving a definitive diagnosis of chest pain along with the rule out. That's completely appropriate. I think the hospital tends to balk a little bit when it's only a differential, or something like just MDA in the final diagnosis, which isn't a diagnosis.
So, it's interesting, when you first talked about this, you said, sorry, we don't want to make sure your inbox is full and packed with things. It's interesting, since we started ICD-10, I haven't had a single chart come back, and I'm sure I'm not quoting everything based on ICD-10.
Right.
But do you guys use the ICD-10 diagnosis? Should we be putting that in our final impression, or it doesn't matter for you?
Put the final impression is very specific. ICD-10 cares a lot about laterality, right and left. Fracture sites have to be very specific. What I've noticed with this group is two things. One is that Medicare's come out and said there's kind of a 1-year grace period, so that if you're not as specific as possible, if you're in the ballpark, there's not going to be any penalty. And then also, as we go through and we started coding this, because ICD-10 is no walk in the park for coders, I'll be honest with you. What we have found from this group specifically is we find the information we need, just not in a convenient location. So it doesn't make its way into the final diagnosis. We see it and it's like, okay, I need some more information. Then I gotta go start digging through the chart. You really don't want coders digging through your charts. And so, I mean, we can provide you some specific feedback on what you're not documenting. You might not like it, but we can definitely tell you, okay, yeah, you never give me right or left. I always have to go look at your x-ray result. You use fracture wrist, and so now I have to go find that it's distal radius, those types of things.
So
we can normally find the information, it's just buried.
If I put under motor vehicle collision, and I don't put other person hit by other motor vehicle initial encounter.
I'm not worried about external cause codes. We've always had to go digging for those. But when you put a final diagnosis of motor vehicle collision, I don't have a definitive diagnosis. So now I got to go look. Did they come in because they had pain to their head? Did they hit their head? Was there any injury documented in the exam? That's time consuming. Sure. Motor vehicle collision, no injury. Now that's a diagnosis. Now I've got it. So that's what I'm talking about being specific. So it brings us back to our 3 key components. That's MDM. So coders, once they've gone through and figured out the acuity level of the patient, now I have to go through and make sure that I have enough history and exam to support that. That's where your down codes come from. This is where I'll tell you that there's a down code. Normally it's in ROS with this group, but yeah. So just to kind of refresh your memory, history's got 3 components. History's made up of history of present illness, or HPI, review of systems, ROS, and PFSH. HPI, we don't see a lot of down codes, but I always like to mention it because you can see that the level 4 and the level 5 require 4 elements of HPI. That means that since they both require 4 elements of HPI, what happens if you don't give me 4 HPI elements? Let's say I've got that chest pain. Remember that chest pain patient that comes in, full cardiac workup, everything's negative? That's still a high acuity patient, so I'm trying to get a level 5 on this. If I only have 3 HPI elements, it doesn't down code to a 4, it goes all the way down to a level 3. It's a severe, significant 2-level down code. A level 3 is what we give the earache patient that gets a script and goes home. You don't want your chest pain patients being coded like that. So 4 HPI, and it could be 1 word on a chart. Oh, so frustrating. So 4 HPI elements. Again, we don't see a lot of down codes, but it doesn't take many down codes for HPI to really have a significant impact. Here's where we see down codes with your group, is review of systems. For a level 5, review of systems 10 or more are required. You all don't use the statement here, you individually document systems. But I also understand there's some rumors flying around here that if a patient goes home, you only need 2 review systems.
Yes, can you squash that?
I'm being recorded squashing that right now. Patients that go home are not necessarily excluded from the level 5 cases. Those chest pain patients go home a lot of times, don't they?
There's an insurgency that has promulgated itself for years that despite our education to the contrary, that a patient may have such a intricate, complex workup, present with significant risk factors, and have an MDM that supports their potential diagnoses and workup and interpretations and medical decision making, and they go home. They still may be a level 5.
Absolutely.
We know that. It happens with regularity.
Yes.
And we also know that level 5 may mean all the medical decision making you may do may be quite sufficient, and you do two review systems, it's not going to happen. That's also known. We do not promulgate, nor have we ever promulgated, that anybody goes home only needs 2. Okay. So there is somebody who perseverates and does an insurgency to keep saying that. It's never happened. I don't know if I've ever said that.
When we first switched, we have heard it, and the residents, go back to the residents, they've heard it as well. When we switched from doing all reviews, you know, whatever language we used to use, normal, we started out, and the easiest way for us to teach this information to our residents, we said, as a general rule, if somebody goes home, as a general, and after that, we subsequently try to backpedal and try to teach them and say, hey, if you still did everything on this chest pain and you ruled them out, it's a level 5.
Yeah.
That's what we've done.
Great.
But there's a last-ditch effort to hang so concrete that not allow for any sort of stretching of the boundaries that you actually could go home and have a level 5. Everybody wants it so concrete.
It's okay.
Yeah.
Others want it that way too.
And
by the way.
we've indeed given physicians their profiles, their down-coding profiles, which primarily involve review assistants.
On discharge
which primarily
patients.
involve discharge patients.
Exactly right.
You know we've done that in the past, right?
Yeah.
And so we've told them that. And I've told the residents, if there are any questions, talk to your attendant. Do you think this was enough of an evaluation for a patient of enough risk to do 10? We've done it.
We do enough outside third-party payer audits where and we'll get that comment from an auditor. Well, you know, we don't think you should have billed a 5 because, you know, after all, the patient went home. And really, when you start looking at those patients, the risk to the patient that you send home is actually higher than the risk that you send to the patient upstairs.
Right.
That patient is going to get further care. The one you send home is on you.
Well, I mean, I guess my question would be, and it might be a question for the group, in today's climate with where everything's going, and now we're worried about these rack audits and these, you know, automated charts and stuff, is it a good time? I mean, we put together a good chart at MCS. Is it a good time to go back to including that statement of, you know, if this is our biggest downcoder, if it's one of the main causes of these uniform charts, I mean, why don't we go back to the statement? Yeah.
You mean group normal?
Yeah.
So here's the reason.
On my dying breath, it will be
I'm so not touching that one.
No, it will be get rid of the streak, that happened. Number 2 is 2 versus 10, and number 3 that ain't never gonna happen.
So
group normal is never gonna happen. You do group normals with your templates.
Let me clarify just real quick before you. So we've talked about for years that, you know, there've been carriers. WPS for a while tried to push it and they dropped it. Trailblazers for a while tried to push it and they dropped it, where they were not going to allow the LS systems negative. And we've been telling groups for years, best practice is to document 10 individual systems. Well, just here recently, CGS, which is another one of the Medicare MACs, came out and said that they are going to require 10 systems in the review systems to be individually documented before you can say all of the systems negative, implying that all of the systems negative means 14 systems that are listed within CPT that we've talked about before, not just the 10.
Yeah, it doesn't get you.
So yeah, exactly. So what you've been doing best practice for a while is going to put you way ahead of your peers in the industry when CGS says now we're going to start auditing and penalizing physicians for this.
So if the residents are putting 10 review system for every single chart, that's problematic, isn't it?
Yes.
But it's not required on every single chart.
No, I understand that part, but I'm just saying, like, in terms of a resident, I think what we can do,
It's
where
not-
we
I
can
don't
do a
think
better
it's-
job, I think, at this point, is telling our
It
residents
is
certain
more
things,
work.
like, if you're placing an IV, if you're giving 3 nebulized treatments, it's very likely that that's going to qualify as a level 5. I think we have to just, you know.
But don't you guys, like, if you have a patient you think's gonna be admitted and may go home, I'm not gonna, like, document up on the decision making, and now they gotta go back and start adding these review systems, and that's just gonna, and if I don't do it, then I got this down bill chart, then I got somebody telling me this code, this is down coded because you don't have a review system, so I asked them and I put them in. So maybe I look like one of the bad doctors who's putting them in every time on almost all of my charts, except for when you're in ARC. But I put them in because I'm not going back. I document my charts up in decision making after I
The
see
key to
the
that,
patient.
Sue, would be
What?
if an auditor came in and said, okay, it looks like Dr. Corian's put it using 10 review systems, and we pull out and say, well, let me show you her ARC charts, the walk-in, and where she's doing 2.
Yeah.
Then, okay.
But keep in mind that history and exam aren't the driving force in code selection. So I will never overcode a chart because you over-documented ROS.
No, it's just
So-
preventing down codes.
Correct. It'll be downcoded if it's not there, but just because you have a full ROS, it's not going to take your intake to a 4 or a 5
Right.
Because I don't.
because medical decision making is not going to be there
But I don't do when I'm in the ARC, so that I don't want them to say, oh, she does that on all the time. It's just like.
all the time. Yeah. We don't
Yeah,
expect to see
let me
full ROS
clarify.
on every.
You guys realize if you go see your PCP, every time you go see them,
And
you're-
review system.
yeah, absolutely. You're gonna fill out a sheet that says, you know, I haven't had this, I haven't had that. It's a complete
You're
review
filling out
system.
the-
Every single time.
There's a
The
tick
alert,
mark.
the alert
All
is for
normal.
when your review of systems is always the same for every
Yeah.
patient.
That's what I'm
Right,
saying.
and they're never going to be like that when you're documenting individual systems. So you have your standard normal
So
stuff.
our
They're going to vary
primary
based
concern
on
here is
complaints.
like rack audits in terms of these 10-point review systems. Otherwise, we could just be educating our residents to actually ask the questions and document a 10-point review systems.
The
I mean,
key
rack
is
audits-
problem pertinent review of systems.
Yeah.
A review of systems that addresses the reason that this patient presented to the emergency department today.
But a rack audit
Whatever that is, in your opinion, as a clinician. And we haven't had, guys, we're not having RAC auditors, we're not having third-party payer auditors give us any pushback on review of systems or HBI.
No.
That's not what they're doing. It's on what Kelly started out with. It's on medical decision making. It's on medical necessity.
When's the last time we got a rack audit on a level 3
Yeah.
and they said you documented too many review systems?
Not happening.
They're worried about them paying us for those level 5s, and that's what they're looking at.
Well,
Did you have a
we
question?
know from our downcoded chart reports, like a badge bleeder, for example, which
Yeah.
we see a lot of.
Yeah.
They can be billed out as a level 5.
Absolutely.
If you have 10 review systems. And then you're faced with, do I have to ask 10 review systems because I know I can bill this as a level 5, or do I need this information to take care of the patient? 'Cause
Right.
you don't need to know about their ear pain if they're there with vaginal bleeding. So I find myself not wanting to ask the 10 just for a billing purpose. Like, it
Sure.
doesn't feel like the right thing to do.
Understandable.
So then when you
Just
find out
understand
that
also that you will receive, but the down code is more feedback, you know, hey, I could have coded this as a level 5, however, I didn't have the documentation to support it specifically in the ROS.
But this is set up for us to, you know, you never need to put 10 for any patient, if you think about it, for any complaint, but this is what medicine is set up as.
Yeah.
And we have to, unfortunately, play the game.
And I'm not gonna ask you to do anything you're not comfortable doing from a clinical standpoint either. Don't do anything just because you're gonna get paid if you do it.
But you never need it.
But we kind of do what the guy back there
This is
told us.
being recorded.
What you need to remember is that there's going to be certain charts where, you know, we're just gonna have a disagreement about what you think the service should have been and what we do. We have to have all 3 key components, and the guidelines are written in such a way that, you know, a patient who presents with high complexity, high medical decision making, that generally, if you look at the 3 key components, that they're going to have a complete history. They're going to have a complete exam. That's kind of what they expect. Does every single patient fit within that? No. Which is why we talk about, we're going to have some of these areas where the coder goes, well, it qualified as a 5, I didn't get it. Clinically, if you didn't think you needed to do it, that is, you guys as a group in your individual practice, that's your decision, and that's okay. And as long as that's around 3%, 2%, I'm pretty happy.
Right.
Pat might have a different deal, but we're kind of okay. We think there's some room to agree to disagree in there. It's for clinicians who get 10, 15% where we go, no, you need some education. You don't understand what you're doing not just to your reimbursement, but what you're doing to providers downstream. We're going to see that patient, look at that record, and try to figure out why you did what you did for this patient, and why you didn't do some of the things that, why didn't you ask about that?
And why does that happen? Does it happen because you're poor documenters, or does it happen because you maybe undervalue your own services and don't see the acuity level that a coder would see? I'm a non-clinician. I can look at some of your work and be like, wow, that patient was so sick, and you're like, man, I see him all the time. And we're going to talk about that with critical care. So I think it's probably more that. It was like you don't even foresee this being a level 5, even though coder's like slam dunk 5, because we're looking at it from a different viewpoint.
But unfortunately, it's still, like, the obvious ones are obvious. Like, the ICU ones, we know we need to document all this stuff. But you look at the classic epitome of urgent care is the woman who wants the STD check. And I've been told you do a complete review of systems if you do a pelvic exam because you can bill more. But the male of that doesn't get that. So you're billing 2 different things for the exact same exam.
Yeah, an STD check is not going to get to your level 5 area.
I was told I was doing a GYN exam to document the entire everything.
Now I will say this, pelvic exams, when the patient comes in and they're having abdominal pain along with it that generates the need for that pelvic, well, you are maybe looking at level 4s, possibly even level 5s. But that's true with any abdominal pain patient. But just a simple STD check, probably not going to get up to those high levels.
Well, we've had some clients who decided as a group, this is what our normal, this is going to be our group's clinical practice pattern. And it really is not necessarily related to trying to increase the bill at all. As Kelly said, you're not going to make an ankle sprain a level 5 because you gave 10 of your systems. We just had a chart coming up in an audit here recently where the auditor wanted to make it the higher level, and we went, absolutely not. Just because they got a complete review of systems doesn't make the ankle sprain a level 5.
Sure. I don't think we want to go up, we just don't want to go down.
Absolutely.
Right.
Yeah, absolutely.
And I do think this is probably the longest we've ever spent on ROS slides, so congratulations.
You told us we're kind of bad.
You are kind of bad, that's why I'm talking about it for a while. Family and social history. One item from at least 2 of these different categories is required for a level 5. Did want to mention that past medical history and surgical history, it's all past medical history. So you might label something as a past and then a surgical. You only get credit for a past medical history. So past medical history we usually see. Family history or social history is also going to be required. Family history just isn't pertinent to every case, so that's usually the one that's not there. But social history, these are questions you probably know the answers to. Are they married if it's an adult? Do they smoke? Do they drink? Are they employed? If it's a child, do they go to daycare, exposed to secondhand smoke? Those types of things. So very important to document that. In the observation arena, all 3 of these are required. If you think about what goes into observation care, chest pain, shortness of breath, psych cases, family history does become pertinent to those cases. But I think in your standard level 5, family history is not always important. So concentrate on past and social, and if family history is appropriate, you can mention that as well. Because for a level 5, and you don't have to say anything fancy, you can say past history negative. Wouldn't do that for social, negative for what, drinking, smoking, whatever. But make sure that you're at least 1 item from 2 of the 3 categories. And exam, I rarely see examination down codes, but just as a refresher, for a level 5, there are 8 organ systems required in your examination. You don't have to elaborate on any system except for the affected system. Make sure that the affected body system is more than just normal. So if a patient comes in with abdominal pain, the abdominal exam, first of all, has to be there. Second of all, it shouldn't just say normal. It's fine if it's a normal exam, but normal bowel sounds, no tenderness, no guarding, no rebound. Be specific with your negatives for that affected body system or area, and the rest of the systems can all just be negative after that if the exam is normal. Teaching physician attestations. A lot of information on this slide. Don't worry, I'm not going to read all this to you. So we do see probably the best teaching physician attestation statements from this group than I've ever seen. There's a separate addendum. It addresses, not only it ties in the resident information, but it also ties in your personal evaluation of the patient, your history, your exam, your thoughts on all of that. It's textbook perfect. 2 things I will point out that we could do maybe a little bit better outside the E&M. Don't forget that when a resident performs a procedure, the teaching physician has to go through and document the supervision of that procedure. So if the resident places a central line, your attestation can't just say, resident placed central line, under my direct supervision, or I was present when resident placed central line. You have to make sure that you document your involvement or your presence during the key components of major surgical procedures. So, and I think central line's number 1 here, where we see that the resident's performing that without your indication that you were present for the key portions or supervised the procedure. So just keep that in mind. Second of all, I don't think you have your residents documenting a lot of critical care time, which is good. We don't code for resident critical care time. It has to be the teaching physician documenting their personal presence for all critical care time. In other words, you need to be the ones documenting the critical care time, not the residents, because you can't bill for resident critical care time if you're not there with them. Any questions on teaching physicians?
Significantly better practice to use our current teaching physician addendum separate document rather than putting an attestation at the end of the resident's documentation?
I personally think it's a lot years ahead of just a statement on the resident documentation. The way that you're looking at, I mean, it's classic textbook best practice because it's so unique to each patient. It's not a rubber stamp by, seen and agree type of thing that is questionable because now every chart looks exactly the same.
Well,
so I do think that your current
that time. You said about putting it in the residence. What, you mean the resident documenting the?
I'm saying that there's the EDD done by a resident, and there was a suggestion that the teaching physician attestation or involvement could be basically a continuation of that resident documentation in the EDD rather than a separate.
Well, one of the things that got brought up in the morning session when that exact same thing came up is that if you're waiting for the resident to complete their documentation, where do you put that?
Right.
Well, not only that, you got to remember, I could see where particularly an auditor, but even a coder would get confused about whose statement that is. Because the resident can't document the presence of the physician.
Right.
The physician has to document the presence of themselves with the resident. So tacking it on to the end of the resident documentation, you would blur some lines there. That one I would be very careful of.
I mean, our medicine colleagues do that on the inpatient side with their H&Ps, and it is pretty clear. It's like says something like attending addendum or something, sort of headlines.
It would need to be highlighted and specific to,
It's minimal necessary.
Yeah.
And your best practice, why would you go from best practice to minimal necessary?
What I said in the group this morning is, in the 20 years that we've been doing resident documentation when CMS came out with the rule for the modifier, we've had 0 issues. All the audits that we've had all the years, we've had 0 issues here because your documentation is very clear about your participation in that patient's care. And so we've never questioned GME funding about bleeding over between getting double dipping or any of that stuff. It's been just rock solid. And so my tendency is you might cut some corners somewhere, but boy, what you've been doing is working really well. I don't know why you want to mess with it.
Thanks.
I know I'm running late. Do I need to
Keep going.
just keep going? Everybody's like, oh man. Everybody's favorite topic, critical care. Probably the most underutilized code in emergency medicine. And it goes back to what we were talking about earlier, is that you're probably just undervaluing your services. What is critical care? Critical care is 3 components. Do you have a critically ill or injured patient? Did you perform a life or organ supporting intervention? And did you document critical care time for that patient? And we see time and time again, and it's not just you work in a very busy environment, but we see time and time again where it's really easy to identify that there's a critical patient, there was an intervention performed, but the performing provider just simply, you're the experts guys, you do this all the time. And you probably are undervaluing your own services and not appreciating the fact that you saved somebody's life. Yeah, I see those all the time. It's critical care. So I want to kind of give you some tips and tricks on how to identify them, because normally what we're missing is you guys identifying them as critical and documenting your time. I can't do anything about that other than tell you, hey, you missed a case here, or this potentially could have been critical care. I think criticality, there's some definitions out there from CPT and CMS. I mean, I think it's pretty obvious what makes a patient critically ill or injured. These are just some examples, and they're by no means a comprehensive list of what I call the slam dunks. You'd have to tell me when these wouldn't be critically ill or injured patients. And do we have any of those cards? Did we bring any of those?
No. Yes.
We actually have these examples on little cards that are portable that kind of help jog the memory, because really it's normally you guys just not remembering that these are indications of critical care. Intervention. So the patient's critically ill. And by the way, when we're talking about criticality, we're not talking about potential criticality. It's not like that chest pain patient that everything was negative and still got the high risk. Criticality, they have to be critical. They can't potentially be critical. And so it's fine lines, but it's a distinct point. And number two, you gotta do something about it. What's your intervention? Life and organ supporting interventions. It's a variety of things would qualify depending on the presenting complaint and the patient's issue. Sometimes it's a procedure like CPR or intubation. Central lines can qualify as interventions. Sometimes it's medications. Sometimes it's fluids. Fluid resuscitation can be a critical intervention depending on the critical nature of the patient's problem. So don't forget that medications can also be critical interventions, especially anything, you know, when we see medications given via drip, I mean, we're just looking for the critical care on those. Drips usually indicate a critical patient. I'm not saying it's, you know, one equals the other, but definitely drips are a great indication of critical care. So when you have a patient that you're having to administer a drip, probably already have the criticality on that patient just because you're having to give that to them. And now it's all up to you. You've got to be able to, at the time you're rendering the treatment, say, hey, this patient's critical, I just did an intervention, let me record my time and make sure I document that. So how do you count your time? It's a minimum of 30 minutes. So 30 minutes of critical care time has to be there. So it's not just bedside time now. You can count a lot of activities towards critical care. As a matter of fact, you can count virtually everything to do with the patient's care except when you're seeing another patient, obviously we're billing separately for that, or when you're performing a separately billable procedure. The intubations, the CPR, the central lines, the time spent doing those procedures have to be backed out of critical care. But everything else that you do, talking to others, talking to family members, documenting the medical record, as long as that patient is there and alive in the emergency department, you can count that towards critical care time. So I had a case brought up this morning about patients that, I mean, efficiency with getting patients whisked off to cath labs have really taken that off the table for emergency medicine to bill critical care. The efficiency is great for the patient, but there's less than 30 minutes of time, generally speaking, that the patient's in the ED. So while they fit the bill for criticality and intervention, they don't fit the time component. Still give you a level 5 on that as long as you give me those ROS. So don't worry about that. But virtually every other patient that comes in, if they fit criticality and intervention, there's usually a minimum of 30 minutes of time being spent in these cases, with the exception of the patients that are in cardiac arrest and don't survive that event. Because once CPR stops and the patient dies, critical care also stops. It is an important point to make is that there's been some recent information about critical care documentation. Some recent audits that came out that talked about the main issue with the critical care charts wasn't the documentation of criticality, it wasn't the intervention, it was the way the docs reported the time, that they were giving time ranges. I spent 30 to 74 minutes in critical care for this patient, so we do need a specific time. An estimate is good. You know, you don't have to be exact. You know, every chart shouldn't say 37.5 minutes or anything, because that's a little weird. But it should be more specific than a range of time. And also, best practice here is to include in your critical care statement the fact that you know the rules and you've already subtracted the time you spent doing separately billable procedures. That's just best practice. That takes all the guesswork off. So if I'm billing critical care, intubation, and a central line, your critical care statement can really help support that time by saying, I spent 35 minutes of critical care time, which excludes the time spent doing separately billable procedures. Just takes any question out of it. So that really is best practice. Some examples, and I'll go through these really quick, so it's been a long day for all of you. Remember, we're looking for 3 things. We're looking for criticality, intervention, and a time request. All of these examples have everything I need. It's 22-year-old, we've got severe asthma, so we've got a critical presentation. There is aggressive inhalation therapy, that's the critical intervention, and a time request of 45 minutes. I bill critical care every day for that. 9-month-old, we have a critical presentation, decreased activity, temp of 103, vomiting, watery diarrhea. Definitely a critical presentation. We've got active cooling, IV infusion therapy, that's our critical intervention, and a time request for 30 minutes. That's one a lot of providers would say, really? Yeah, really, that's critical care. And don't forget overdoses. Not every overdose gets to the point of critical care, but when they present like this, they're already altered. There is bicarb infusion, gastric intubations, charcoals, definitely life and organ supporting interventions, and a time request of 35 minutes. It's critical care. Any questions on critical care?
We're not doing this.
Enough.
I know we're not doing it.
There's more potential. I think some providers are a little bit better at identifying this. It's not the way these patients are being treated, it's the way the provider is able to identify their critical and remember to document the time. That's the only difference. And so if I've helped you today identify maybe 2 more cases this month, it's just important, because when you don't ask for the critical care, we're undercoding your services even if we code a level 5.
I think one of the things, you and I had emailed back and forth, and I think you sent me a list of like the 10 most common things that our group misses on, or like the 10 most common ICB codes and what we're missing critical care time on. That might be something, I don't know if on the intermedics tab we could build in something like that, or where you basically said this is where you think we could be hitting. And it was really common stuff we do all the time. Like all of our BiPAP people and stuff like that, we're missing a lot there. In the heart failure, which we see a lot of, we're missing that all the time.
Yeah,
so
BiPAPs are big, yeah. No, I'd forgotten that we had swapped those emails, so yeah, it's really important.
We have marginalized critical care to the sickest of the sick.
Yeah, you have.
And we have failed to appreciate this intermediary where the actual participation of decision-making, the patient's risk, that's what we forgot. We exist in an inner city urban level 1 trauma center where
you've seen it already.
And the sickest of the sick and said, they're critical and all these others aren't. Where if we got out into the community more, the majority of emergency medicine, it'd be markedly different.
I've heard it described as, if you're not sure if a patient is critical or not, imagine that patient walking into a PCP office. What would they do? Would they pick up the phone and call 911? Probably a critical patient. And so it's a good litmus test to think about. EKGs, I only want to mention really briefly. We do bill separately for EKGs. The documentation is usually good, except for we don't always get that separated out. Remember that when we bill separately for a diagnostic interpretation, that it has to be a separate identifiable report, just like a specialist in the field would do. And separate doesn't mean a separate piece of paper, but it does mean you need to separate it out and not jumble it into a long-running MDM, labs, x-ray, meds, and the EKG findings, because that doesn't make it a separately identifiable report. Make it into a separate paragraph, a separate header, and just separate that out. We're actually having to send some of those back in the missing files to have those done. So. And ultrasounds. We don't currently bill ultrasounds for you guys, but we wanted to talk a little bit about possibly doing that and what it would take to start billing ultrasounds. When we talk about ultrasounds in the emergency department, we're really talking about bedside or limited ultrasounds. And these are ones that I think probably the most common ones are, especially in a trauma hospital, your FAST exams, your EFAST, your abdominal, and probably your obstetrical. Those are going to be your most common. But we see a little bit of everything. The biggest hurdle in billing for ultrasounds isn't the documentation, because the documentation is relatively simple. It's the fact that in order to bill for those, you have to retain an image of that bedside or limited ultrasound. Even if you're like doing an ultrasound guided central line, there has to be some capture of that ultrasound image that's recorded and held on to for posterity. And so a lot of groups have trouble doing that, and that's one of the main reasons that we don't bill for ultrasounds, because other than that, the technology's there, the technology's being used, and the documentation's pretty simple. What do we need for documentation? Well, it's kind of like that EKG. It needs to be a separate report. You need to tell me, anatomically speaking, where was the ultrasound placed? And what did you find when you looked at the ultrasound? It's pretty simple. There's no set number of elements that need to be documented. Just tell me where, what you found, and any impression that you have from that. Especially if it's a fast exam, make sure you call it a fast exam. If it's an abdominal, make sure you tell me if the patient's pregnant or not. Then tell me what you did or didn't find, which are your findings, and then any impression that you gleaned from that. Once again, it does have to be a separate paragraph, with the exception of your ultrasound-guided procedures. So an ultrasound-guided central line, for instance, your ultrasound documentation could just be part of the procedure note when you're placed in the central line. It doesn't have to be a separate one like this. Any questions on ultrasounds? And we're going to wrap up with everyone's favorite topic, PQRS. The 2016 measures, you'll see a familiar one, which is the EKG for non-traumatic chest pain. Pretty easy. If we see a patient that comes in with chest pain, we look to see if an EKG was done. If it was, we put a 3120F on the claim. You get credit for performing this measure. This measure's been around for a very long time. That's really easy. It is when the measure doesn't get completed that coders really struggle a little bit, because if a measure is completed, you just report it. It's great. But if it's not done, so I have a chest pain patient, there's no EKG done, I have to add a modifier to say why it wasn't done. Was it a medical reason? Was it a patient reason? Did they just refuse the EKG altogether? Or, unfortunately, did it just not get done and you didn't tell me why it didn't get done? That's usually the case if an EKG doesn't get done. This is poor quality. We'll still report the measure, but it's reported as poor quality. And remember that PQRS is basically your Medicare report card, and this data can be shared with others. So I think the takeaway message here is that if you don't perform the measure, you don't do an EKG on a chest pain patient, just tell me why. There's reasons, there's valid reasons for not doing it. We just need to know why so that we can steer clear of this poor quality measure and say, oh no, that patient refused. Or, oh no, you know, the equipment was broken, something. Just tell me why it didn't get done. I love these next two. Now, these next two are PQRS measures for Medicare patients that involve pregnancy. A lot of pregnant Medicare patients running around, right? And it's about ultrasounds for pregnant patients with abdominal pain to determine the location of the pregnancy, and ROGAM for Rh-negative pregnant women. Again, these are all Medicare patients, ages 14 through 50. Keep in mind that Medicare also covers some disabled patients, and so you actually can have pregnant Medicare patients. The volume is quite low, and we don't really see a whole lot of this. So I do want to mention those because if they do come up, we are reporting on those. But really the big new thing last year was this cross-cutting measure for high blood pressure. So I just kind of want to take you through some of the ideas on what this measure is. This measure basically states that any Medicare patient age 18 or older, that if their blood pressure is measured in the emergency department and it is high, high is considered anything above 120/80. I didn't make that up. That's pretty easy to hit. So if their blood pressure is high and they don't have an exclusion, so they're not an urgent case, they don't get admitted, they don't already have a history of hypertension, then this measure says that they're looking for you to say, you know what, Sally, your blood pressure was high today. You should go follow up with your primary care physician about that. That's what the measure is about. So keep in mind that this could impact virtually any patient over the age of 18. But let me tell you, there's a lot of exclusions that come with this because, first of all the blood pressure readings have to be above normal standards. So if at one point in time they've got a normal blood pressure reading, this measure doesn't apply. It's only when they're constantly. So, and we can still report the measure. We just report the measure and say, hey, this patient didn't qualify for the measure. If the patient is an urgent case, which means they're admitted, a level 5, so even some of those discharges, level 5 acuity, so even if you don't do the ROS, we'll give you credit for that, or they're critical care, that's an exclusion. You're not thinking about their follow-up time, you're worried about today's visit and worried about the urgency of today's care. So they're excluded as well. So again, we'll report that, you know, yeah, their blood pressure was abnormal, but they had an exclusion. The measure didn't apply. If they already have a history of hypertension, or today you treat them for hypertension, it's another exclusion. Why would you tell somebody to follow up with their primary care physician for a diagnosis they've already been established? They're probably already receiving care for that. This is just for that niche of Medicare patients over age 18 that all of their blood pressure readings were high today, never been diagnosed with it, not an urgent case. Hey, your blood pressure was high today. You should follow up with your primary care physician. It's all they're looking for when it comes to that measure.
But you're saying it's 120 over 80.
Yeah, just the messenger.
Either
number.
125 over 80 on a 19-year-old, and I'm telling them to follow up, get his blood pressure rechecked.
If they don't have a history of hypertension.
That stood out to us too. I don't know,
Yeah.
it's the CMS's rule.
But, I mean, how many 19-year-olds are on Medicare?
Well,
I know.
but even, okay, so let's say it's a 66-year-old.
Yeah.
I wouldn't have an issue. I would consider it almost low if they were 126 over 80. If they were 80.
Well, then congratulate them for their low blood pressure and tell them to follow up with their
Yeah, no, we saw that one too. And
Yeah.
Really?
We struggled with this a
Because
lot.
I do this all the time for people with, hey, your blood pressure's high, but you know, higher.
Yeah, I know. It seems very low threshold.
How are they abstracting it? Like, because we don't obviously include every single vital sign while they're in the ED
Right.
in our notes. There could be one that's fits the less than 120 over 80, but the one we documented is higher than that, and we don't counsel them. So how does that?
It's a great point because we're only looking at what's in your, I think it's usually in your examination. And so it's a great point that if you've got other readings that would be normal, you might want to try and slide that in, or even if you make a comment later, repeat blood pressure now within normal range or something like that, then we can say, hey, this measure doesn't apply versus penalizing you when it really didn't apply. So great point. Thanks for bringing that up.
So all of us dictate the blood pressure, most of us, I should say, dictate the physical exam. And most of us in our disposition say, discharge home, follow with primary care doctor.
Yeah, but it's got to tie it back specifically. Yeah. Nice try.
It's got to specifically
got to tie it back to the DP. You have to say your blood pressure was high today. You should follow up with primary care.
You have to elevated blood pressure referred to.
Yeah.
That you can, and the history of hypertension or the excludes is if your past medical has hypertension above it, game over.
Game over, yeah. Doesn't apply.
Yeah.
Or if you treat them today for the hypertension, if it's high enough to where
18, not past medical history of hypertension, elevated blood pressure against those, say it.
Right.
Or if you treat them today, you give them clonidine or something, and say, oh, your blood pressure, you give over. Because you're not going to tell them to follow up and treat it at times.
Very good.
All right.
So what happens if you don't get any of these? What's happening with Medicare? I mean, this is a reimbursement problem.
Right now,
it's punitive.
Punitive.
Yeah.
Well, it's punitive if you don't report. Today, it's still reporting today, but obviously the intent where CMS wants to go with this is pay for performance. So what they're trying to do is, emergency medicine is really we're getting the short end of the stick. I mean, they're really stretching. You look at these measures, you go, really pregnancy measures and blood pressure measures that are 120 over 80, and they're really having a hard time coming up with emergency medicine measures.
Yeah.
Most of the measures that are out there are primary care related, where physicians they've got more frequent contact, they're not seeing them during an event, they're seeing them during the course of just normal evaluation. And so they're really struggling with what to do with emergency medicine. And the interesting thing about that is, the interesting thing about that is that the first specialty that presented a report to Sue Nesda, who used to be in charge of the PQRS program from CMS, came from emergency medicine. Yes.
Well, I was just gonna say, you said this is what CMS is wanting to do, but is what we're doing now not already gonna affect us in 2017? Does go?
They're already started this year with some bundled pricing. The orthopods this year started out with bundled pricing for hips and knees, and so.